Welcome back to our roundtable discussion. In this section, we're going to talk about how the community clinician uses guidelines today. We have in the NCCN guidelines a whole panoply of regimens that are listed in the second to fourth line space. And now, in addition to the three drug regimens, we have CAR T cells. So the question is going to be, how do you decide on what kind of therapy to select for your patient? So Adriana, how do you decide triplet versus CAR T versus something else?
Yeah, I think that's one of my favorite parts of working in myeloma is that we now do have so many different options and really can tailor the therapy to the patient in the room. We've discussed a lot of these. I think in the relapse, we have the bonus of having information of how well a patient responded, how long they responded for, and how well they tolerated a prior therapy. So that can inform what classes of drugs we should either consider using or not. I do generally favor quads in the front line, but remembering that the quad is not a forever therapy. We start with a 4-drug regimen, but quickly sort of given their response, break it down. So usually most patients who will be relapsing won't be refractory to all 4 classes. So I certainly would consider revisiting the ones they haven't seen in a while. As my colleagues discussed, I definitely agree. Young, fit, functionally high-risk patients, those who are unable to reach an MRD negative response in their first therapy, or that remission doesn't last for 12 months, are the ones I really tend to favor CAR T early on. But patients who, to Natalie's point, have a difficult time coming to the center, we have a number of very effective options that can keep them local, but I would engage and start the conversation. I think one of my biggest things is, as the field gets so complicated so quickly, having a buddy, to say, in a myeloma center that can work together with our community partners really, I think, yields the best results for our patients.
So, Natalie, one of the main questions that one often gets, especially in first relapse, is a biochemical progressor. Do you distinguish their care in any way from that patient who is having overt symptomatic progression?
I do. I think one of the things that we've learned is that patients who meet a definition of either high risk at diagnosis or they're the early relapsers, again, within 12 or 18 months of therapy, they're probably the people that you shouldn't just be watching a light chain level increase or an M protein increase. Those are probably the individuals that I would have a very low threshold to treat. Now, unfortunately, and there's a lot of discussion about this in our worlds about how to modify some of our on-study criteria, because right now, almost every study is built that you have to reach a certain level of protein before you can be eligible, which is kind of unfair, I think. But there are definitely individuals who have very slow progression that I will sit on. I want to just make one comment about NCCN guidelines as somebody who's pretty involved in this. We get a lot of flack about all of the many regimens that are listed. But one of the reasons to do that is to actually assure access for patients. As Adriana said, there are people who need an all-oral regimen, for example, who can't come to a center. And by having them included on the NCCN guidelines, that can be a way to make sure that they can get access, because insurance companies often pay attention to this. And that's really why we end up, some people criticize the laundry list, but there are some good reasons for that.
Oh, I know that you guys on the NCCN committees are faced with the task of making sure that patients have access to drugs, and insurance companies obviously look at these guidelines to, for most part, provide access to drugs. So, Ajay, do you do anything different for your biochemical progressors?
It goes back to what Adriana started with. There's always patient, disease, and treatment factors you have to consider. And so you might treat a high-risk patient who's supposedly relapsing biochemically because the writing on the wall is that person's going to progress. If somebody's had a long remission and it's an early biochemical, you may have many months to even years. But one other thing that I wanted to highlight, I think, is probably, other than the general oncology principles of patient disease and treatment, I really want to focus on drug resistance, because I think we're increasingly understanding the importance of drug resistance in sequencing. And the vast majority of patients in the US will be lenalidomide refractory at first relapse. And why is that important? Even when you use a non-cross-resistant regimen like Dara, Velcade, Dex, and Castor, your PFS goes from 16 months to 9 months, even though you're not using an IMiD. And so that just shows that when you use a drug till progression, it generates biochemical disease changes that will affect your salvage regimen. And so I think the single best prospective long-term follow-up data we have for len resistance in terms of mature PFS readout is CD38 KDs, right? So ESA, DARA KDs, which have PFS of 3 years. Cilta-cel may also get there, but we don't have that PFS readout yet. But the problem is, if you're an older patient, you may not tolerate carfilzomib as well. So now, what do you do? I think that's the biggest challenge is in MAIA. We know that DRD is great and your PFS is 5 years, but then once you progress, that OS of MAIA sits right on top of PFS. How do you salvage somebody who's 78 or 80, who's now DARA and len refractory? And I think number one should be a clinical trial for those patients because we really don't have that. And I think to close out that discussion, basically there's like 5 dance partners we have, right? We have len, POM, Wart, CARF, and CD38. And sometimes the other kid that gets invited to the prom is cyclophosphamide, but eventually use up all of those partners. And if, particularly for those older patients, if you're CD38 and len refractory, POM-based regimens are at best going to give you a year from what we know. CARF may not be well tolerated. And, so you have limited options. I know we're going to have a later segment about Bella, but I think we need novel MOAs, particularly for older patients that are both CD38 and len refractory.
And just one little point that, I think 2 things that I see when I get second opinions from the community is what really is a biochemical progression or not. And, and I would say, make sure that you check an image. If you see a patient that is having their M protein go up, to make sure you check an imaging study to make sure it's not a hard relapse. Because I've had patients that have biochemical relapsing that I want to put them on the clinical trial. I'm like, you're relapsing, you're ready for a clinical trial. And then it's a year until they actually relapse, and I'm imaging them along the way, and the clinical trial is closed. And I'm like, well, it's a good thing that you are slowly biochemically relapsing. But make sure you check those imaging studies. And just like Dr. Callender said, that the people who I am willing to treat sooner in a biochemical relapse, even though they haven't had a hard relapse, those patients that had aggressive disease at the beginning and have imminent end organ disease, people have had really short responses, maybe quad refractory up front, and patients that have high risk cytogenetics.
I think that's well brought out. So I presume by imaging, most of us are probably doing PET scans these days.
Absolutely.
Vinod, do you?
I was saying the same thing for the biochemical relapse. For high risk, I have very low threshold to treat because we have seen even in the initial trial with the MRD, monitoring, we saw that for high risk patients, even before they go to biochemical relapse with the MRD resurgence, there's already writing in the wall that there is a preface to clinical relapse very quickly. So I think you want to intervene. But I think for the standard risk patients, I think it's a discussion between patient and you. But more importantly, I think I'll look at the velocity of the relapse. What is the tempo of the relapse? If you're doubling the M protein very quickly, every 3 months for that patient, I think I would be more inclined to treat, even though they don't have any clinical signs. So I think that is a little bit discussion for the standard risk, but for high risk, I'm definitely going to treat those patients even for biochemical relapse. And I think going back to Ajay's point is very critical. I think we are using up these very effective regimens early on, right? And going back to len refractory patient, even in those IKEMA and IKEA, they're not like len refractory exclusively patient. They include everybody, not like CARTITUDE-4 study, which just looked at the len refractory. And we did look at those patients on both the trials, all data-based trial, in a pooled analysis. And we saw that the PFS for patients who had the len refractory is actually very poor. It's not like what we saw in IKEMA or Candor, because not all patients can get that, right? So I think those are the things that we need to discuss about, like what is the next best treatment they have. And for older patients, I think having the clinical trial with the novel mechanism of action is probably the next thing to do.
And then along those same lines, from Karma 3, when you take a look at the patients who were assigned to standard therapies, these are patients who were triple class exposed. A lot of them were triple class refractory. Their median PFS is 4.4 months. And I think that just underscores Jay's point here that that's a bad group of patients that really need new options.
Yeah, and that becomes more critical as we have more quad exposure, and almost everybody becomes quad exposed in the first line. Then what is the natural history of those patients, exposed versus refractory, and how to, tackle those patients. I think that becomes like another unmet need in the second line.
Valid point. So let's shift now to toxicity. And since, CAR Ts have been the ones that have now appeared on the horizon, we're going to probably concentrate mostly on the toxicities that one has observed with CAR T cells and how to manage them. So first of all, I think we hinted upon secondary malignancies, but in that we also talked about the presence of mutations perhaps pre-existing that lead to some of these. Now, the other thing about, CAR Ts is often the prolonged cytopenias that one sees. So, Adriana, have you seen prolonged cytopenias and how do you manage them?
Yeah, that's very good. I think we always focus on the acute toxicities of the short-term CRS, neurotoxicity, and cytopenias, which I would say, depending on the product, we see different rates. But beyond day 60 is where I start to consider them prolonged, because most patients have resolved their need for growth factor support. And it's really the neutropenia that worries us. As we mentioned, similarly to the secondary malignancies, there are other abnormalities in the marrow, many of which, when we go to look, predate. So still an area, I think, more of questions than answers, but we're learning patient selection and optimization. We have had very few patients who beyond their 6 months remain needing support. And we've had a couple patients we've used stem cells to repopulate and help them recover. Others were found to still have circulating T cells at that late stage, and targeting and eliminating the T cells sorted the cytopenia. But it's the good thing is they are fairly rare, but the rarity makes it difficult for us to really come to conclusions and get consensus on either risk or management.
Anybody have any other pearls of wisdom about the cytopenias?
The cytopenia and the ERS, or the inclination to use the stem cell boost, is very variable. If you look at the literature in the CARTITUDE-1 patient and KARMA, I think the prolonged cytopenia is 10 to 15%, right? In CARTITUDE-4, we saw about 10%. So I think that number is going to get better as you move early on, because the marrow is probably much robust. That's kind of biologically probably possible. I think the urge to give stem cell boost, I think, is so much variable. Some people don't want to wait for 2 months. Some people just want to wait for 1 month, and if there is grade 3 cytopenia, they start giving the boost. And you have seen all the real world studies of stem cell boost, and it is so much variable. The rate is 20% in some centers and 15 to 10% some other centers. So I think my practice is somewhat like Adriana's. Like, I usually wait for 2 months, support them, and majority of the patients do recover by 2 months, but there are some patients who definitely need to do the boost. And I have done maybe out of maybe 50 patients, maybe 1 or 2 boosts in my practice. But at our center, I think even there is a variability, and you will see, like the rate might be higher if you ask somebody else.
I would just add that maybe cytopenias leads to another overlapping AE, but one thing to just, I think, for the audience is what's striking is after these CAR Ts, most of these bone marrows are MRD negative, right? So you're still cytopenic, yet you've eradicated the myeloma. So it goes back to what's really the pathophysiology, because everybody's familiar with anemia from myeloma, but now why are you neutropenic? Why are you thrombocytopenic if there's no myeloma? And I think the mechanism, my guess is it's probably immune mediated, right? But I think I agree with Binod and Adriana. We tend to do stem cells if they're available as early as 1 month, because they're usually an empty marrow with no myeloma. And what are we going to wait for? If we're going to give the cells, might as well just give it. But we also need to just keep in mind infection and our management of infections, right? So when I was at Sinai, we checked CMV, and about 30% of patients will have CMV reactivation. So making sure that there isn't a viral contribution to the cytopenia. Concurrent medications, right? Many people use Bactrim for PJP prophylaxis, and some patients don't tolerate that, and maybe switching to an alternative drug. But I think infections is the other thing we should mention, that what I think, even though in CARTITUDE-4, again, in CART-1, we couldn't tell what was the infection from. Was it because these are heavily treated patients with terrible myeloma, or is it because of the product? And I think CART-4 tells us that the overall infection rate is quite comparable to the standard of care arm, but the devil's in the details, because the use of IVIG is much higher, right? It's like 60% versus 10%. So you're getting the same infection rate despite using a much more frequent IVIG. And I do think many of us use IVIG in the post-CAR T period because they are hypogamma, and it takes probably about 6 months post-fludarabine cyclophosphamide to get the count recovery, CD4 recovery. So I think infections is important because we are seeing in these CARTITUDE studies that there are some deaths that are not due to myeloma progression. And what are those from? Some of those are from infection. So really, we need collaboration with community to be, look, I would say like in general, T-cell redirection patients should be almost treated like allogeneic transplant patients. Look for those unusual infections that you might not think of in a regular myeloma patient. And so working in close collaboration with infectious disease and the CAR-T referral center are important to keep our patients benefiting from the myeloma control.
But I would kind of add when we send patients back to the community, that we definitely, relay that risk, the infectious risk to the community and really, watching, being able to mobilize and get the IVIG going. Because some mistakes we've seen is there have been gaps where, we give them IVIG in the initial period while we're kind of watching them at our center, and we send them back, the IVIG falls off, and then they can end up with an infection. And so, it's definitely staying on top of that IgG level and kind of watching it.
I think there was initial concern about using myeloid growth factors to support patients post-CAR-T, and I think we all feel that concern is gone. So by all means, support people with G-CSF if their counts are low. And then I think it's a little bit less clear whether thrombopoietin agonists help at all. But I think we don't feel that that's detrimental, I guess I would put it that way. So certainly those things can be utilized. For the patients who continue to have cytopenias that are going on, we will keep them on for a long time. And, we try to use inhaled pentamidine just because it's somewhat easier and then we don't have the count issue. And I think we are leaving our patients on acyclovir up to a year after the CAR-T, certainly.
Anybody have any different practice patterns on the length of?
No, I think one of the questions that I was looking at some of the patients, post CAR-T and when to start IVIG. Usually I tend to do later on because they will see an effect of hypogamma later on. But I have some patients having like IgG level of very quickly drop even very early on. So I think that is something that we have to think of, like replacing that and looking at that way, because you don't test the IgG level that quickly, right? Once they recover that, first couple of months, then you start testing it. I think I have seen that drop very quickly as well. So I think might be worthwhile, because if you look at all the NRM data, whether it's a clinical trial or the real world studies, the NRM, more than 50% cause of NRM is infections. And I think, we saw that first 9 months, even CAR-T 4 patient, most of the patient died in first 9 months. If you look at the death rate, that is quite high compared to standard of care. And there were COVID deaths and there were a lot of other deaths, and majority are because of infections. So I think that is very, kind of important, data that from both real world and the clinical trial that helps us to, treat those, identify that, as I said, monitor them and identify and treat them aggressively.
To pick up on that thread, I think we should also highlight that this is really target specific as well, right? So BCMA is, yes, it's plasma cell, but it's a little dirtier and you have profound B-cell aplasia. And that's why you see with the BCMA bispecifics, there's a relentless increase in infection because you're repeatedly targeting that antigen. Because CAR-T is more of a one and done, we're more worried about that initial 6 months as opposed to the indefinite. It goes back to like vaccinating patients for COVID prior to CAR-T, because nothing's going to work in that first 6 months. So, and to that point, if there's a new COVID pandemic, working with your ID doctors to think about COVID therapeutics, because these patients will have no immune response to these kinds of organisms. So I think those are important to keep in mind, peri-CAR-T.
Moving on from infections to other toxicities, I think that the ICANS and CRS is something that most are managed in the center. And by the time patients get out, the community doctors are usually not having to deal with that. And fortunately, CRS and ICANS with BCMA-based therapies are not as bad as some of the CD19-based therapies, but focusing on some unique toxicities that have been observed. So, Craig, what about delayed neurological toxicity? There's been some chatter about that. So what is your observation and what would have you to say about it?
There definitely was some of the higher patients that have been more refractory, and we've seen more therapies that we've seen a bit more of the neurotoxicity. Thank goodness, the numbers are very low. And when we've been using it in earlier lines of therapy, we haven't seen as much, to the point that, we're always very conscious of patients that have prior neurologic diseases going into CAR-T and being careful to, make sure that we communicate with their neurologist if they have a seizure disorder, if they have Parkinson's disease, to say that, things may get a little bit worse or could get worse as a toxicity to the CAR T. There are reports definitely of patients having long-term neurologic toxicity from CAR T. We haven't seen very much of that at all.
What is your take on cranial nerve palsies that are also being reported? Are these self-limited usually? Or are they requiring some intervention? If so, what intervention?
Yeah, I think that's very important because the Parkinsonian get a lot of attention, but they are exceedingly rare. Whereas the cranial nerve palsy, especially cranial nerve number 7, seems to be fairly common, reported about 10% of the time. And those do tend to be 1 to 2 months out. So likely when the patient is returning or possibly being seen by the local physicians. And those with a rapid course of acyclovir and dexamethasone, so far my experience has been they've all been resolved within 2 to 4 weeks.
Anybody has a different experience?
Yeah, I think the cranial nerve palsy is essentially everybody gets resolved. There's no question. I think the time to onset is very variable, but most of the time is within a month or two. And I have one patient who had like grade 2 and then went to grade 1 for like almost 2 years, but finally resolved. So essentially everybody resolves with cranial nerve. And we really don't know why that happens because it's not dependent on the disease burden. I think this is something that really, and facial nerve seems to be affected the most than other nerves, but I have seen like diplopia and some kind of just weird sixth nerve palsy as well. So I think that is encouraging that even they do happen, they do resolve. I think the key, thing that we really need to understand is about the risk for MNTs. I think that's the more debilitating, and I haven't seen any patient recovered from that, at least in my practice. I have like 1 or 2 patients who developed that. And it seems to be a class effect. To be honest with you, it seems to be seen more pronounced in cilta-cel, but we have seen that in the ide-cel, there are reports coming out from there, and even other BCMA trials we have in our place. And that has reported having, MNT like syndromes as well. So I think, the Mount Sinai group, what they looked at that BCMA expression, whether that is because of that, or we really don't know. I think that seems to be the major concern, not only for cilta-cel, but any BCMA CAR T therapy.
I'd like to add maybe that Anu Kumar from UCSF is actually leading an effort to collect all of these delayed neurotox from around the world. And so I think we've highlighted the 3 ones, right? Parkinsonism, cranial neuropathies, but the third one that we should also mention is peripheral neuropathy, Guillain-Barré syndrome. And I had a patient with that. It can be quite devastating, right? Somebody's MRD negative and then you can't even walk and you're weak, and it's really impacts the quality of life. And I think for both this and the cranial nerve palsies, we don't really know exactly what to do, but I think many of us would do steroids as a first pass, and then also IVIG. I mean, it almost like a CIDP. Our neurologists at UCSF are doing a lot of research labs on these patients, but they're being treated almost like a CIDP with high doses of IVIG. And I think the last thing I would add to this discussion is this is where caregivers really need to play a role as well, because if somebody has cognitive slowing or flat affect, the patient's not going to report that to you, right? And it's the caregiver who picks up on it. And that's why a lot of the patients are counseled and the caregivers are counseled that if you notice anything abnormal, it doesn't matter how silly you think it is, let us know so we can image, test, get the right consultants appropriately. Because I do think that early steroids use, in my experience, does make a difference. And I think if we let people sit on these for a while, we may be missing an opportunity to reverse the AE. And lastly, the cranial neuropathy, while I think reversible, again, speaks to quality of life impact, right? And you're giving potentially high doses, protracted steroids, increasing infectious risk. So it's a pain, but I mean, it's not a reason not to do CAR T, but it is something we have to counsel patients on.
And I think just from a scientific point of view, the fascinating thing is that this is just sort of not a big problem in CD19 directed CARs. If you talk to our lymphoma colleagues, they're just not seeing this kind of neurotoxicity that we are, this delayed neurotoxicity, this particular category. So I think we still have a lot to learn about just which patients really are at risk for it. And is there any mitigation strategy up front you should be thinking about doing to try to prevent this? But I think those are really important questions that hopefully we'll figure out in the next couple of years.
Yeah, quickly, I think on the same line, if you look at the BCMA versus CD19, the 2 things are common is infection and the second malignancy. But this delayed neurotoxicity seems to be unique to BCMA. So I think this is something really, further research needs to be done, like how to avoid or how to mitigate that, it seems to be something that target related.
Well, there's a lot to think about with our patients. Ajay, what are your key takeaways for practical approaches to the second to fourth line care for community physicians today?
Use the most active regimen available to you for the patient based on patient disease and prior therapies, and keeping in mind the efficacy safety balance of the novel therapies that we've outlined: neurotox, infection, secondary malignancies.
Greg?
I would definitely say keep in mind clinical trials. That I think that in no other time in my career have there been such a plethora of excellent clinical trials that are available for basically every disease state within multiple myeloma, but definitely concentrating on that second to third line disease state. And so I would, definitely encourage everyone that, refer for clinical trials, or if you have clinical trials available, help the science and enroll patients on trials.
Natalie?
So I would say sort of R&R, you have to review and reevaluate. So what has the patient had? What kind of toxicities did they have? What do they have right now? What do you think the tempo of the relapse is? What are the available options? What's their distance from the cancer center? What kind of caregiver situation do they have? All of those things can help factor into selection of your choice of therapies.
Adriana?
I think one of the important things as the field is getting complicated is to reinforce most of us who do nothing but myeloma are so happy to engage in communication with our community partners. So please call us, please let us help, detangle the many, many options that we have.
And last but not the least, Binod?
No, I think I was about to say the same thing Adriana said. So, it is so complex, from in the front line. And in second line, even more complex. So when we have so many therapies, as you already said, so I think it might be difficult to choose one versus another one. I think having the patient seen and having this shared decision together with the academic center, with the specialist, and try to see what is the best option for that patient, I think the key. Maybe CAR-T or may not be CAR-T, maybe some other treatment for that patient. So I think their shared decision making with the academic doctor probably should be the goal.
Thank you for sharing that insight. Next, we will look forward as we explore how things may change as new data accrues in the second to fourth line setting. Don't miss the next chapter. Thank you very much.